This is our second town hall. We did one 2 weeks ago. The purpose of these town halls is to give you medical information. What are the facts? What's the mythology? This way we can all conduct our lives with more confidence and with the knowledge that we're doing the right thing. Just as an example, a few weeks ago, there was a rumor that 5G was causing coronavirus, and we were able to quickly debunk that. And we'll go through some more questions of that nature as we move on. I also want to take a moment to really shout out to our healthcare heroes, some of whom are on the line with us. Where would we be without our healthcare providers? These are not only physicians, these are the nurses, the respiratory therapists, anybody you can imagine working in a hospital. They have been absolutely incredible, putting themselves in harm's way and exposing their families to risk as well. And I can't tell you, I've seen signs like that. I've seen sheets hanging out of windows, handmade signs all over the place. In fact, I almost got in an accident trying to take a picture of one. The work of our healthcare heroes is really being acknowledged. We are very grateful to an air demonstration by the U.S. Air Force and U.S. Navy when the Thunderballs flew overhead. They flew over Newark Airport. They flew over our hospitals in New York City and Long Island, again, to honor our physicians. They did this today with the Blue Angels over the Washington, Maryland area. In New York City, Mayor de Blasio is so grateful for the work of our healthcare providers that they're actually going to have a ticker tape parade when the health circumstances permit. It's promised to be the biggest and best down the canyon of heroes in New York City. There's so many kinds of jubilation that we experience, a whole range of emotions for when people don't do well, but also our successes. And this was a picture taken from earlier in the week. This gentleman went to Spain where he became infected, and he was probably one of the first patients admitted to a New York City hospital, Mount Sinai West, on March 7th. He was the 500th person discharged from that same hospital on April 29th. And what we see here is the intensive effort that it takes to treat the most severely ill. Now, some of us may not even know we've been exposed. In fact, the majority of us will have a mild illness, if any at all, but some will be severely, severely affected. And this was one of those gentlemen. And when you think of the incredible energy, intense efforts it took on the part of so many individuals to get this man up and running again, it's absolutely mind-boggling. And the thrill when someone like this leaves the hospital. We see here he's going down the exit, and a lot of the people from the intensive care unit came down. They're appropriately masked, separated by 6 feet, applauding his discharge. I know there's a local hospital near me. Every time a patient is discharged, they have one of the Beatles songs go on the entire hospital speaker system. And here we are. We're practicing social distancing. Our world definitely changed, and today we'll learn more about what we should expect. But clearly, one of the most important lessons that we've all learned is a term called social distancing. I think at this point, we all agree it's physical distancing, where we're physically separated, but we still want to be very, very social. We want to communicate with the most vulnerable people in our populations. We want to communicate with other people, see how they're doing. And I can tell you, I'm very grateful for all the text messages and phone messages I get from people asking me, how am I doing as a healthcare provider? These little touches are extremely important as we move forward during this crisis. So keep on practicing your social distancing. And please, today, I'm going to be watching, make it a good practice to not touch your mouth, your nose, or your eyes. On that note, I'm going to bring in our first speaker, Dr. Tsoline Kojaoghlanian. Like many of the doctors who are speaking today, she has her full-time job, and on top of that has a full-time job in medical philanthropy working with our organization. And we're so grateful to have her. She's extremely knowledgeable. She's at the nexus of all of the activities in New York, dealing with the state, local and federal governments in terms of a COVID response for her hospital. She is a pediatrician by trade, board certified in pediatric infectious disease, an associate professor of pediatrics and pediatric infectious disease at Maimonides Hospital in New York City. So without further ado, I'm going to let Dr. Tsoline Kojaoghlanian speak to us. Thank you, Dr.
This is part 2 of our webinar. We covered some of the basics in the first session 2 weeks ago. So I'm going to pick up where I left off then, but for sure, by all means, whoever is here today and didn't attend the first session, ask us any kind of questions you like in the chat box, that whatever we don't cover today. So again, a reminder, this disease is called COVID-19 because CO stands for corona, V stands for virus, D is for disease, and 19 is for 2019 because that's when the virus was first discovered and came around and started causing disease by being transmitted from one person to the other. And again, a reminder, this is a novel virus. It's a brand new virus that human beings have never seen before. Therefore, we have no baseline immunity to it. And that's one reason why this virus is spreading so much. And one reason why we don't know much about it is brand new. And all the information we are gathering is new, both how the disease is, both how our response to it is. And the information changes really, really fast. And therefore, we are giving you information updated as of the day that we are speaking to you. Some things remain the same, but some things change as we learn more about this new disease. So I'm going to mention what we know for treatment of this virus. Obviously, we're all desperate to have something, a magic bullet that will kill this virus and make us feel better. And unfortunately, I can tell you that as of today, we don't have any proven treatment yet for this disease. Many people are working to find something. Of course, you've all heard from day one in the news about hydroxychloroquine. The convenience of this is that it's a pill, you can take it orally. However, as of today, we don't have any data supporting its efficacy, meaning we don't know yet whether if we take it, we're going to prevent developing severe disease or not. And actually, there is some data showing that it has considerable side effects, to a point that last Friday, the FDA came up with a statement cautioning people against the use of hydroxychloroquine outside of the hospital setting or outside of a controlled setting because of its risk of the side effects, particularly heart rhythm problems. This was followed the same week by the NIH guidelines. This is the National Institute of Health of the US government. The treatment panel recommended against the use of the combination of hydroxychloroquine and azithromycin, which is the Z-Pak, which again, I'm sure you know many people were using and may continue using, but we are strongly advising against it because again, there is no data that it works. And there is data that there is toxicity associated with these medications, especially when they are given together. That's number one. Number two is remdesivir. I'm sure all of you heard about it in the news this week. It is a medication that unfortunately is given in a vein. So you cannot take it at home. You have to be hospitalized or in a setting where you can get it intravenously. Now, this is a trial whose conclusion was just released. So the actual data, the details of how this trial was run and conducted, we don't know yet. But this was done in the US and Europe, and it included 1,000 patients who received this drug when they were hospitalized. And there is the preliminary results of this trial are that maybe there is some modest improvement in patients who receive remdesivir. And that improvement was described as those who received remdesivir had 30% faster time to recovery. So they left the hospital probably 30% faster than those who didn't receive the drug. So clearly this is not, again, a magic bullet, but it was encouraging enough that it made it to the news and looks like the FDA is going to approve it to be used a little bit more in hospitalized patients. And then in hospitalized patients, we're also giving something called immunomodulators. We have mentioned last time that part of this disease, especially those who are hospitalized and have severe manifestations, is actually because of the strong immune response, overactive immune response against this virus. So therefore, there are some drugs that are basically trying to target that immune response, trying to dampen it a little bit, to dampen the damage to the organs from that overactive immune response. And lastly, you have heard about convalescent plasma, and these are antibodies that we take from recovered people. So we draw their blood, we have to make sure that they have enough antibody that could help another person. And this, again, cannot be done in the home. It usually is reserved for hospitalized patients. But none of these, the way I described them to you, are proven to work yet. They are all mostly in trial settings. We are all, trying our best to see which one is going to win, or maybe we want 2 winners, 3 winners, the more the merrier, so that we can have something to treat this disease either at the early stages at home, or when you get hospitalized with complications. So, and of course, vaccine we still don't have, but we'll leave that to the question area. Next, I want to focus on the testing for COVID-19. You're hearing a lot about it, so I wanted to explain a little bit what it is. There is 2 tests to test a virus, 2 different types of tests. The first one is looking for the virus itself. So is the virus there? Is it in my body, yes or no? This is also called a PCR. And the sample for this is collected from the nose, the back of the throat, phlegm or saliva. And it is collected when somebody is actually sick with symptoms, even though, like Larry said, some people may have this virus and they may not know they have it. So you could also potentially test those kind of people and find out if they have the virus or not. But it's usually when you are symptomatic that the virus is going to be there. And you can get the results depending on where you live, which state you live, either same hour, same day, or several days, depending on the setup. But there are problems with this virus. It's not widespread yet because, again, depends on the state, whether you have the test readily accessible, number one, or even if you have the test accessible, we may not have the swabs necessary to collect the samples. That's why people are trying to see if saliva is going to be enough rather than collect the sample with a Q-tip swab that goes in the nose or the throat. So, and that's a major hindrance to have testing much more readily available for those of us who might have mild symptoms and want to really know, is this COVID-19 or not? So because of these issues, we are still telling people, stay home if you have mild symptoms. Don't rush to the doctor to get tested, because one, you may not have the test available, and I'm going to let Dr. Raffi talk about that after me in his setting, or because we also don't want the disease to be transmitted yet to other people. And one more problem with this test is that, especially with the tests that are offered in doctors' offices, where they tell you, oh, I can find out in 15 minutes if you have the test or not, like the rapid strep test that you guys know. The rapid strep test has been around for years, has been validated, has been studied extensively. The ones that are available right now for COVID-19 are very few, and those that are in the market are really giving what we call false negative results, meaning you might have the virus, but then when you test it using these rapid tests, you might get a negative result and you're like, oh, I don't have it. Meanwhile, you actually have it. So again, we want to stay away from these kind of offers where they tell you, okay, I'll get you your result in 15 minutes, because these tests are not very well vetted yet. The second type of study that you're hearing about a lot is what we call the antibody or serology test. And this is actually looking for our immune response to the virus. Not the virus itself, but how did our body respond to it by producing what we call antibodies. And that happens with all kinds of viruses. It's our natural response to a virus. So potentially it will be a good thing to have. And so the sample collected here is blood. And because our immune response takes some time to develop, it is not there from day one of infection. Therefore, this test needs to be obtained at least 3 to 4 weeks after you recover from the sickness. So when you are acutely ill with fever, cough, shortness of breath, this test will be negative because our body hasn't had time to develop an immune response yet. So we need to wait at least 3 to 4 weeks to have this test done. However, as I said, ideally, this would be a good test to have. But again, remember, this disease is brand new. So the tests that are being launched are brand new. And we don't know yet how they're going to pan out, what they will mean, what the results will mean. And what makes things more difficult is that, unfortunately, the FDA has allowed up to 150 manufacturers selling their products in the US market, but they have only vetted or approved 10 such tests so far. And these are the tests that are performed in large commercial labs like Quest, LabCorp. So therefore, the majority of the products in the market, guys, are unvetted and therefore unvalidated, and most of them are inaccurate, right? And I don't know about you, but I don't want to have any test that will give me inaccurate or invalidated results, because it really gives me a false sense of security, because I cannot do much about the result of that test. So even in the ones that are approved by the FDA, those 10 that I mentioned, even if you test positive with those, because again, it's a brand new test that was just launched, we don't know yet what positive means. We don't know if it means you are protected from future infection with this virus. And also, let's say you do have some protection, we don't know how long that protection will last. So the jury is still out. Don't rush calling your doctors and demanding this antibody tests, because honestly, as I said, it will not really answer any of your questions. So therefore, currently, these tests should not be used to diagnose you with past COVID-19 infection or to inform you if you are immune to it or not, as I just explained. Their utility currently is really for population surveillance. You have probably heard that New York State has such a test. They're going to supermarkets, randomly talking to people and taking their blood, fingerprint and a finger prick, and having an idea of how many people in the population in a certain town, in a certain city, in a certain village are positive. And that's fine, because that's an approximate number. If I say approximately 20% of the population in New York City is infected, great, that gives me information. But do you personally want to have a result that's approximate? You probably have immunity, you probably are fine from reinfection, you probably are okay for the next 3 months. So at an individual level, or probably or approximately, are not good enough tests. And that's why we're saying don't rush yet to get these tests. And similar to the PCR, there is also tests that are done, again, finger prick, right away in the doctor's offices. Those are the inaccurate, invalidated tests I mentioned. So for sure, stay away from those kind of offers where your doctor tells you, oh, I have it, I'll give you the answer in 15 minutes while you're still waiting in the room. Because there is portable antibody tests, as I said, that are out there in the market, but those results are extremely unreliable. Okay, so the next 2 slides, I'm just going to show you again what we saw in New York City. And as you can see, this is the last peak is really starting March 11 all the way to April 25. You can see that we had a peak of influenza-like illness and pneumonia in the emergency room, emergency rooms in New York. And it is divided by age. So as you can see, the green one is age 75 and up. The orange one is 65 to 74. And even people between 45 to 64, which is the purple, then the brown is 18 to 44. So you can see that up to March 11, we were fine. And mostly we were seeing kids. The blue line before March is just kids with influenza, tons and tons of influenza. And then all of a sudden we have old people coming into the hospital with a very sharp peak, and this was all COVID-19. But you can also see that after April 10, we have a decline in this peak. It's because, guys, we stayed home, right? So the reason why we have this sharp peak and then the decline right after is because we stayed home, and we succeeded, I would say, in making the peak not go higher and higher and higher and higher. So of course, now that we are on the downtrend, and you see that we're almost approaching the pre-March 11 levels. So that's a very good sign. And those are signs that we are looking for to be able to reopen or come out of confinement, or however you want to call it, unpause. Each state is using their own terminology. So we really need to look at certain indicators to be met to start this phased reopening. It's true that we went home from between March 10, March 11, we went home. It was a light switch, but the coming out is not going to be light switch. It's going to be phased out. So what do we need? What indicators do we need to meet to start this phased out reopening? So we need to see signs, like just like the graph I showed you here. We need to see signs that we are on the downward trend in all these states where we live in. And that means that the spread of novel coronavirus has slowed down. And ideally, we should see this downward trend sustained for 2 weeks. So we don't want to see it down and then back up and down and then back up. We need to see it for 2 weeks sustained, which means we need to see much less new infections. And the way we're going to know new infections is by testing people. If I don't test, I don't know who's infected and who's not infected. So less positive virus test rates translates to less infections. And once we see that we have less and less infections for 2 weeks, that means we have it under control, we can start coming out. Another indicator is much less hospital admissions for COVID-19. Another indicator is much less critical care or ICU care beds full with COVID-19. And on the other hand, you must have heard that we need more manpower to track, to start testing more and tracking these COVID-19 hotspots, trace the contacts of people who are infected, and isolate them so that we can again control it in a small setting rather than let it expand like it happened in March. So, and these restrictions will first be eased for people not at high risk for severe disease. And reminder, the high risk are the diabetics, obese, hypertensive, chronic heart or lung disease, immune compromised, kidney disease, or pregnant. I'm just going to end with this slide. I always feel like visual makes much more sense than letters and me speaking. So you can see why we are saying that once even we start the phase coming out, there are certain things that we're still going to do to prevent the virus spread. And because the virus is spread by droplets that are coughed or spoken by an infected person and inhaled by a non-infected person, there is some data to support that the mask will help reduce that transmission. So if you see that if 2 people on top are not wearing masks, then the risk of contagious is very high. If only the uninfected person is wearing a mask, but the infected person is not wearing a mask, the risk is still very high. If the infected person wears a mask, that's the third one, and you are not wearing a mask, the uninfected, you reduce a little bit the transmission because the infected person is covered, but it's still as good as when it's both are wearing masks. And obviously, the longer the distance between the two, then it's very low. And it's 0 when you are at home, right? When you are not exposed to anybody. So these are going to be the wearing masks in public when we need to, and other measures we can talk about in the question session are going to be important things to follow once we start coming out. So I will stop there and leave the floor to the next speaker.
If you can leave that slide up, there's one point I think we could make when you see these people sneezing. And that is the mask will definitely decrease the amount that the person on the other side of the sneeze will receive from their nose and their mouth. But the virus can, the particles, the droplets of this virus can enter the eye. So this is why when you visit your healthcare providers, most healthcare providers will be wearing some kind of a face shield or eye mask. This is why I would personally, as an ophthalmologist, recommend that you can wear your contacts when you're home, but when you're in public, wear your glasses. The glasses will be one extra barrier of protection. It also reminds you not to touch your eyes.
Yeah. And this is just another example, guys, of why we're doing, because everybody's, frustrated why we're home. We're really doing this for the good of the general public. Yes, we're protecting our own parents and grandparents, but we're also doing this for the general. And the same is the mask. The mask really is the person who's infected is protecting the uninfected. I feel like it's a beautiful gesture, and that's the concept that's nice in this one.
I think another thing to add to that, what you were saying, we're still not even sure. We know it's droplets, but we're not even sure if this is aerosolized yet. So they're still looking into that. So this is very important. And when we do protect ourselves, the guys who are testing on the front line, like Larry said, we're wearing goggles and protecting our eyes because it's very important.
So this is just for the general public I was talking about. We also have the contact, right? This is the main way is the droplet, but we also have the contact. That's why Larry mentioned how important it is to wash hands and not to touch the face and the eyes and the nose. So those are all things that are going to remain with us for a long, long time.
Tsoline, we have a very good question. We keep on hearing how important it is to wear a mask. But the question is, should babies wear masks?
So no, anybody under 2 years old should not be wearing a mask because the risk of asphyxiation in a child under 2 is much higher than an adult. Similarly, if a person, older adult, has any inhibition about wearing masks, meaning they cannot take good breaths if wearing masks, or they are not mentally capable of managing their mask, those are also people who should not be wearing masks. So there are exceptions. And again, we don't want a false sense of security that, oh, I have a mask, that means I am the only place where the risk is 0 is the bottom, right? When one is home and the other one is outside. So there's always a risk when you're outside. We don't want people to think that the mask is 100% protective.
And another question we have is there's different kinds of masks. There are the masks made out of cloth that people either make or purchase. And then there are the masks that we buy in our pharmacies, the medical surgical masks, and then N95. There's a tendency to leave a mask in a car and reuse the same mask for a month. What are the different practices that we should use with our masks, whether they be cloth or the surgical mask? And Raffi, you can chime in also.
Sure. So so there, as you mentioned, 3 categories, let's say. So the face, the most important thing is to make sure that we're wearing it correctly, no matter what the type of the mask is. So it really should be covering the nose and the mouth, not below the nose, not below the mouth, up and down, that doesn't work. So we got to put it, it has to fit snugly enough without making you suffocate. So for the general public, those who are not in the healthcare business, and they're just going to the supermarket and then face the regular cloth masks, as long as the cloth is thick and multi-layered, should be good enough as long as you keep a certain distance from somebody else. And those should be, again, made of something that can be washed in the regular laundry. You don't want anything that you cannot wash because you need to wash them. So for the general public, that's what I would say. The surgical masks are really reserved for healthcare professionals or people in the front line, like police officers, maybe firefighters who are having to go into people's homes, the ambulance, the EMT. So those are the people who really need a little bit, the difference is the surgical mask filters a little bit more particles from the infected person than a cloth mask will. Even though if the cloth mask is thick enough, it probably should be equivalent to a surgical mask. The N95s are really reserved for, like Dr. Raffi said, for those of us who are doing procedures with very close contact with these patients. We are intubating them, we are giving them some sort of treatment where when they are coughing in our face, and we have to be close to them because we are taking care of them as nurses or doctors. And N95 comes from the number 95. That means 95% of particles can be filtered through that mask. So again, in general, for the general public, if you are keeping a distance from others, you wouldn't need that. Number 2, there is a shortage of the N95s. So obviously, in an ideal world, if we had 350 million N95s for each person every day, sure, we could use them. Even though they are, trust me, after 15 minutes of wearing that N95, you want to take it off. So, but in the shortage of N95s and surgical masks, those should be really reserved. And we're not just saying that because we want to protect ourselves and not protect the public, but that's what the data shows.
Raffi, if we did have a surgical mask, I hear people putting them in brown bags. Is that important to do? And does that increase the life of the surgical mask?
It doesn't increase the life. I mean, we are putting them in brown bags because at one point we were trying to conserve the masks, but as we've gotten more PPE, and people have been very generous as far as sending us N95s. We've also gotten K95s, which is similar, not as protective, but you know, at one point we had to conserve, and unfortunately that was what it was. But as we've gotten more masks and stuff, they should not be reused if possible. But unfortunately, a lot of times the hospitals were running out of supplies and they had to reuse them. And there's ways to sterilize them. And the bag can help, but ultimately a new mask should be put on because you're walking back into the same area. It's like not taking off your gown. You don't take off your gown and you keep re-entering those rooms, you're going to expose everybody, your office. So that's a problem.
Well, thank you. We do have a very good question about why infections are so high in New York. And we're going to come back to that when after Dr. Kim Hekimian speaks. But this is a great moment now. Before we go on to Dr. Raffi, Tsoline, there was one thing we didn't hear from you. What happens at 7 o'clock every night in New York City?
This has been going on for the past 6 weeks, I should say, that every day at 7 p.m., every New Yorker comes out of come to their balcony, to their backyard, to their window, starts clapping, starts using pots and pans to make noise. If you are in a car, you start what's the word?
Horn.
Somebody help me.
Beeping the horn.
Honking is the word I'm looking for. Whistling for 3 minutes in honor of and in a thank you gesture to all the healthcare workers and the frontline workers.
Yeah, my friends in San Diego and all around the country have similar things, honking horns, and it's great. They give a shout out to all the healthcare providers. That's nice.
Very good. And I'm sure that's very, very heartwarming for you as someone who puts your life on the line every time you go to the hospital and possibly come home and spread the infection there. So we very much appreciate your talk and everything that you do. All of your volunteer efforts are really so commendable. We're very, very fortunate to contrast Dr. Kojaoghlanian's experience in a hospital which is receiving a lot of COVID patients to one of our colleagues, Dr. Raffi Kapitanyan, who is on the front lines. Dr. Kapitanyan is the founder and owner of 2 urgent centers. For those that aren't familiar with an urgent center, we have physician offices we can go to, and then which are typically open from 9 to 5 during the week. And then we have urgent care centers where people can go with a whole array of medical problems, evenings and weekends and during the day if they don't have a physician, in place of going to the emergency room. So Dr. Kapitanyan is in a unique position to get his finger on the pulse of what's happening in the community real time. What is it like, Dr. Kapitanyan, when you're at your urgent care center? Is life the way it was before March 17th, or has life changed?
Thank you, Larry, for having me. I appreciate it. Things have changed dramatically. It's been very chaotic, and I'll kind of go through what we've experienced starting basically at the end of February into March. Those first 2 weeks, there was a lot of uncertainty. Flu was kind of still around and fading a little bit, but we were still thinking flu was here. And then there was this slow global pandemic that started occurring, but no one was really prepared for it. It was considered a pandemic March 11th, but prior to that, we were seeing symptoms and people and patients coming in, testing for the flu. The flu was negative. We just thought it was just another virus, and we were treating them as upper respiratory bronchitises, pneumonias. And at that point, in those first 2 weeks, that's when my staff and I were the most vulnerable, and we didn't even know it. Unfortunately, we weren't having our PPE and doing everything that we had just discussed about protecting ourselves 100%, which is scary to look at now. Also at that time, the CDC was basically just telling us that the criteria to test these patients, if we thought it was necessary, would just be fever and cough, and they would have to come from a country that was highly infected. So that was China, Japan, Italy, South Korea, and Iran. So we were limiting our testing at that point. We really didn't know what to do. We also didn't have enough supplies. The CDC was limiting supplies to the local healthcare facilities. So as a community doctor, we had a lot of questions that we didn't get answered. Patients were coming in and everything was really uncertain. So after it started to progress, the CDC decided to lift all of the restrictions around March 3rd, early March, but we still couldn't get the supplies. We didn't have the ability to get the swabs. I mean, we had swabs for flu and strep and other tests, but we didn't have anything necessary for nasopharyngeal swabs where you have to really get deep into the nasopharynx. And then we called a couple places and we found out finally that Quest was the first one that was supplying us with some materials. And that was about the first 2 weeks to mid-March, but we still didn't know how to protect ourselves. And that was the scariest part. A lot of people were just using isolation rooms that weren't true isolation rooms. There was not negative pressure, we call it. So we wanted to protect our staff. And then we started reading and hearing about how South Korea started doing drive-through testing. So that was our first large-scale testing we started doing, which was drive-through. So both facilities, we'd have appointments made the day prior. People were coming with their cars. We were getting fully gowned and going outside the building, not to bring anything into the building and expose anybody, and doing drive-through testing, about maybe 50 a day at that point, because we didn't have enough supplies to do that many. Now, people were also walking into the urgent care and didn't even know they had fevers. Most people who had no symptoms had COVID and they didn't know it. And so exposure was there. So it was pretty scary. And then about mid-March is when this test started to come back within a week. So patients were waiting, phone calls. It was getting very inundated and we didn't know how to answer questions. And so all we knew right now was that you're going to quarantine yourself for 2 weeks. There was no work. And then eventually everything came into fruition where stay-at-home orders took place. After that, we started being able to test asymptomatic patients, not just fever, not just cough. And we know now that fever and cough is not just the symptoms. Some people just had diarrhea. Some people basically couldn't smell or taste. Some people just had toe symptoms, where we almost see that in the pediatric population with hand, foot, mouth. They were just having this viral illness. And especially a lot of my pediatric patients, the younger ones, presented with these toe symptoms. And, you know, we didn't really know what was going on, but we started testing more and more. So just to give you percentages, the first week of testing, we basically had about 12 to 15% positive rate, which was kind of on par with what the hospitals were seeing. After a week to 2 weeks of testing, asymptomatic got more and more testing, we started to see a 60 to 70% positive rate. So all these people out there didn't even know they had it. And because we tested more and more, we started building up the cases and the denominator grew. So that was very important for data, for everybody to see what was going on. And that's when New York became the epicenter. And of course, Jersey follows New York always. And so it just became ubiquitous. Anyone who had any sort of symptoms was COVID. It was ubiquitous. So it was getting very scary. And so finally, we progress now from what we're doing with all the nasal swab testing. And then we've come to the point now where people want to know if they did have it. So then we started to find out more about antibody testing. And as Tsoline said before, there are a lot of companies, especially from China, that were sending these kits. These were not FDA approved. Some doctors I know of and don't approve of were doing these from the stoops of their homes and telling patients that they had it or didn't have it, which was just very unethical. There was no evidence-based medicine behind that at all. So we wanted to make sure we had the right test. So finally, probably around the end of March, well, actually more like beginning of April, we started to get approval to do tests through Quest. And this was blood tests. This is through getting blood through the vein, not just a finger prick in the office that's not approved. And then we started sending these tests out. And a lot of patients were coming in, you know, scared. And most people just wanted to know. And unfortunately, we didn't want to just test everybody, but that's what was going on. We were just testing patients who said, I got sick in January, my flu was negative, and I think I had it. And we started testing more and more patients. And as we saw, most of the patients back in December, January, early February, around this area, did not have it. And there are IgGs, which is the antibody that you test for to see if you have, well, if you developed an immune response. We don't know if it's immunity yet. We know it's an immune response. We're just not sure if it has lifelong protection or what it does, which will answer more questions as we progress. And so this is where we are now in the clinical setting. Unfortunately, what's also going on in the clinical setting is no one's coming in for anything else. So we usually see injuries, lots of other infectious stuff going on. We see patients coming with heart problems and all that. All of that went down dramatically. And the ER also in the hospitals didn't see any more of these patients coming in. So a lot of patients were suffering with having heart attacks and dying at home and this and that. So it became a point where everything was COVID and we weren't doing anything else. And then at one point, people didn't want to go to the ER at all, and they were coming to us because they thought we were safer. So we were seeing a dramatic increase in heart attacks in the urgent care setting. We really shouldn't be seeing heart attacks in the urgent care setting, but we were. And that was scary. And a lot of cancer patients were not being seen. A lot of outpatient procedures, biopsies were not being done. And this was scary because everything was put aside. So that was another issue. And then the mental illness was another big thing that took a toll on my staff and I. Talking to patients who, whether they had a history of anxiety, depression, everything was exponentially getting worse. And it was good to do this because I've done it before, but not to this extent. And to be there and see these patients and help them was great. And I got to tell you, a lot of the patients were so appreciative. We had patients in the drive-through that asked me if I wanted a tip because I was like, what we were doing, I'm like, I'm not a waiter, it's okay. And they would even offer to buy our staff, pizza and food. And a lot of local places were making masks for us, which was very generous. So we had plenty of masks. We didn't actually even need any more. We were doing pretty well that way.
Each of you have talked about treatments, evidence-based treatments. There are many studies going on. There's one study that involves taking what's called convalescent serum. If someone's had the infection and they're over it and they donate their blood, we can actually get the proteins that fight the infection called antibodies. And the question is, can those antibodies fight COVID-19, number one? And the second question is, if somebody has recovered from COVID-19, is it something that they should consider donating their blood for a study like this?
It's not just, again, guys, the fact that we have antibodies, because we just explained to you, don't go bother doing the blood test because we don't know what having antibodies means. So when you are going to donate your blood, it's supposed to be done in certain centers who are actually conducting these trials. It's not proven to work, so it's being done in very controlled settings. So for example, in New York, Mount Sinai does it, and not only they see if you have antibodies, but they actually measure how much antibody you have, and ideally they should also test and make sure that those antibodies neutralize the virus. But we encourage people at this point, whoever is willing to help others, to yes, go donate, but the decision is not going to be up to you. It's really the labs taking your blood has to make sure you have enough and to give it to somebody else. But yes, just like we said, everything we're doing for the common good, this is something else that people who have recovered can go. I think Rutgers in New Jersey, the Red Cross, and Mount Sinai, and including my hospital, Maimonides as well, has these programs.
There's so many different kinds of tests for COVID-19. We're getting a specific question about, is there a PCR test available to establish a diagnosis?
I guess maybe I thought mention it in my slide, but I will repeat it. So yeah. Yes. The one test is the antibody test, the other test is the PCR test. The PCR test basically detects the virus itself, and that's what we're talking about when you take a swab from the back of the nose, from the phlegm, or even the saliva. You send it to a lab and they do what we call a PCR that detects the actual virus, actually detects parts of the virus. It doesn't mean that the virus is multiplying. It's not a culture. It says the virus is there. So yes, and those are the tests that we are saying we hopefully should have much more widespread, as Dr. Kapitanyan said, because it helps us make decisions both on the individual level and the population level. If I know I have COVID-19, then I know my diagnosis, I'll go home, I'll isolate myself, I'll make sure the rest of my family don't get it, I don't go out for 14 days. Plus, we will know in the population how many people are infected, because this data of positives is collected. So we will know more and more how many people are infected.
So that test, exactly. I mean, that's what we were struggling to get for a while, and now the availability has increased tremendously, and which is good. And that's the exact test we're doing for our drive-through testing. We're trying to have those patients who are actively having symptoms that we test through drive-through so they don't spread. But unfortunately, we know now that a lot of patients are asymptomatic. So that is a big issue. But that is that swab we put in the nose and that we sent to the lab. The turnover time was a week, and now it's been 24 to 48 hours. So we know the answer is pretty quick now. So that's very good. And just another note about the testing. A lot of people are asking, at least I've heard, after I get the test, can I get another test within 2, 3, 4 weeks and see if I'm negative or I'm healed? That's not the case.
No.
We're actually seeing a lot of patients who the virus, even though it's kind of dead or whatever, it's still shedding in the nasal pharyngeal area. And we're seeing that up to 6 to 8 weeks. So a lot of people are asking if I need a test to go back to work and this and that. That's not happening right now. We can't use this test to say you don't have contagion anymore or anything like that. Again, we also can't use the antibody test to say that, all right, you're not going to spread this and this. So we all need to use these tests with a grain of salt and just be careful, like Tsoline already discussed.
Tsoline, the question is, if we go to the hospital and we have very bad disease, well, I guess the first question is, when should we go to the hospital? And the second part of that is, what percentage of people who go to the hospital actually successfully leave the hospital?
So there's different data on that. I'm going to say that once you're hospitalized, I think at this point I would say it's a 50-50 chance of getting out. But the older you are, then the chances become less. So it depends on each paper is describing a different mortality rate, but we don't have the full denominator yet. And the way sometimes the statistical analysis is done in different papers is different. So I don't want people to read much into that, except that once you're hospitalized, obviously your chances of getting better are going to be lower if you are older in age and if you have comorbidities. So that's how I would answer that.
The patients that we've been seeing, the main issue really is how COVID affects the pulmonary system, the lungs, and it causes an inflammatory response. And people feel short of breath, they have a dry cough. So right now we're seeing a lot of patients that are coming in, and we would typically send a lot of these pneumonia patients to the hospital when they're, and I'm sure you guys have heard about oxygen saturation. That means their amount they're diffusing oxygen. A lot of these patients are presenting with lower numbers than we typically have seen for any sort of pneumonias, and typically we admit them. But most of these patients we're sending to the hospitals, especially when it was getting really bad, were being sent home even with pneumonia and low oxygen saturation. So what I would say to everyone is the main reason you should go to the hospital is if you're really short of breath. Shortness of breath is really the big issue. Obviously, if there's any mental status issues or anything else, yes, but most patients will have a dry cough, feel a little tight in the chest, and as long as their vital signs are okay, it's gonna be okay. You just have to rest. We're also telling patients not to lie on their backs at home and sleep on their backs. Very important, because if you lie on your back, you lose lung volume. So what they're doing in the hospitals are they're flipping patients. They're proning them to increase their ability to diffuse oxygen. So do not lie on your backs if you are diagnosed. On your side or your belly is preferred. But shortness of breath is the big key.
I do want to take one question, Larry, if you don't mind, because I think it ties in nicely with what Kim is going to talk about. It says, how much confidence exists that the virus would run its course in a 14-day isolation period? So there is a little, so I just want to clarify what that means. The virus will not run its course in 14 days. This is a virus, as we mentioned, the symptoms start in the first week. The majority will get better in the first week, but the subset that's going to get sicker and get hospitalized are actually getting sicker during the second week of illness, after day 6, 7, 8, or 9. So during the second week of illness, you are still ill. And once you're in the hospital, obviously it's another week or two before you really leave the hospital. So this virus, from beginning to end, if you're gonna be hit hard by it, it's taking weeks for recovery. But I think what the questioner meant is how long the virus is contagious. And I think that, as Raffi said, we are detecting the virus for prolonged periods of time. But that doesn't mean that the person is infectious for 4 weeks or 6 weeks. Right now, from what we have from the data, it seems that one is probably infectious in the first 2 weeks of disease. And maybe there is a small percentage we will find continue to be infectious on the 3rd week. But it really mainly is those 2 weeks. And that's why the quarantining period is 2 weeks, the isolation period is 2 weeks. Because even if your recovery is longer, you're no longer infectious when you are recovering.
Correct. And we're seeing patients after the 2-week quarantine that are still coughing, still short of breath. So like Tsoline said, some patients have had no symptoms. They literally have no smell or taste, and they're like, I feel fine. How could I have it? Some patients have been weeks. And we are seeing the most severe patients, like Tsoline said, is they get diagnosed almost asymptomatic. And if they have a lot of comorbidities, again, the elderly, people with blood pressure, it's a slippery slope where they're fine and then they crash really quickly. That's what they're seeing in the hospitals, where they go down quick. So again, once symptoms start to progress or anyone feels short of breath, that's when we get concerned, and that's when they need to go to get at least supplemental oxygen and stuff.
And as Raffi said, if you're coughing on your 3rd week of illness and you have to leave your house because there's something urgent, please wear that mask.
Correct.
Right?
And this is also a big allergy time for everybody. So a lot of people are sneezing and coughing and having pollen issues. So like we said, if you were diagnosed with it and you still have it lingering in the nose, even though theoretically you're not contagious, if you sneeze, cough, let's say 6 weeks out, can we say for sure you can't spread it? No, we cannot. So once again, wear your masks, social distancing, be careful.
There's a lot that we've learned being in the epicenter of this disease in the New York, New Jersey area. And I'm happy that many of the people on the phone who I see from Canada and Argentina and California have fortunately not experienced the carnage that we've experienced here. But I can tell you, amongst my friends and colleagues, all of us have thought that we've had coronavirus at one point or another. And the question is, you know, should you call your physician? Of course, you should call your healthcare provider. But there is an app for the Android and for the iPhone that will, it's free. You download it to your phone. It will ask you a series of questions and then give you your risk of having COVID-19 disease. So that is something that I would encourage all of you to do. There was also a shortage of a lot of supplies here in the New York, New Jersey area. One of them was pulse oximeters. There is an app for the iPhone. I believe it's for the Android as well. And you can email us if you want more information about it at info@aahpo.org. But basically it tests your pulse and it tests your oxygen saturation, and it goes down to 94%. So I know we've suggested this app to several people, and it's reduced their anxiety level quite considerably. Now we're going to go to our third speaker, who is absolutely awesome. Again, I don't know how she does it with children, her full-time job, and the full-time job here at AAHPO. Dr. Kim Hekimian is an assistant professor of nutrition at the Institute of Human Nutrition, an associate director of education, program for global and population health at the Vagelos College of Physicians and Surgeons, otherwise previously known as the Columbia Medical School. In addition, she started the program at AUA in Armenia for public health, from which several of the current assistant ministers of health have graduated from. So we know that Armenia is in very, very good hands because of the quality of training that they've received. Dr. Hekimian is going to give us a brief overview. And Dr. Hekimian, we have several questions. One question that you might hit on during your talk, and we can answer it later, is why is New York the epicenter of disease? And is there something different about the virus in New York? And the second question that has come up because of all of the new testing that's available, what is herd immunity? Does herd immunity exist? Because we do hear people now saying, oh, you know, we have 10% of the population who have immunity to this, therefore we can go around with impunity and not take precautions. So having said that, I'm going to let you discuss the subject for us. Thank you so much, Dr. Hekimian.
Thank you, and thanks to everyone for, thanks to Tsoline and Raffi for their talks, and thanks to everyone. The chat room questions are excellent, and we encourage you, and we hope that we can answer them. I think I have a couple of slides that might help answer why New York was, you know, some theories on maybe why New York was harder hit. And I thank you for that question. It came up in the last webinar we had a couple of weeks ago. So I've been asking around and poking around on that. And also there was a request for me to talk a little bit about this concept of the difference between the flu and the coronavirus and why that's confusing in sort of public health messaging. And there's a couple of good questions in the chat if Tsoline and Raffi wanted to look at them that I think that we can help clarify. And one is about masks, as there's a differential in the quality of masks. When we say that you're not protected by wearing a mask, we're talking about you wearing a cloth mask that doesn't completely protect you from the droplets in the same way that a healthcare provider's N95 mask protects them. Everybody should be wearing a mask. And as Tsoline mentioned, in an ideal world, we would all be wearing the highest quality masks, but we don't have enough of those for everybody to wear every single day. And so in light of that, we're taking what we call lowering risk. In public health, we talk about lowering risk. There's never really any zero risk, right? But we're talking about ways that we can, as a community, as a society, and for our families and ourselves individually, each take steps that will lower or mitigate our risk for transmission.
And I'm sure, Kim, you're going to tie this in as to, again, this is not the only virus that's transmitted this way. right? But the reason why we're taking these extra precautions with this virus is because of the mortality rate of this virus so far. And I'm sure Kim will touch on that too, you know.
Yeah, and you know, so part of our issue in public health messaging is, in fact, what Tsoline started off by saying is that this is a new virus. Data's coming in, it's being, you know, aggregated as quickly as it can be, but the lack of testing that we had in this country early on really doesn't allow us to know the full prevalence or the full incidence of this virus. And so we have modeling, and there's a couple of really good, brilliant institutes that are doing modeling all the time, but we're seeing that that modeling is being changed up on a daily basis based on new information that we have. So it's hard for us to know what the true mortality rate is. And data is treated very differently. Right now, in some states, the CDC, the coronavirus is only those who have a confirmed positive test are included in the data. In other data sets, there's probable causes of death that are probably as a result, or that the deaths of people who had probable COVID but were not tested. So there's a lot of stuff to unpack here that is confusing, and we're here as an organization to try to make it clearer for you, and also to not make you feel so afraid, right? And that's what I think I mean by saying that there are mechanisms. Washing your hands, not touching your face, these are mechanisms that are proven for all viruses and lower transmission in general, right? So I'm just going to share a few slides with you to get a couple of these issues, and then I welcome an open discussion. So this was a slide I showed a couple of weeks ago, and while the data is not updated, I really think that this kind of hits home for New Yorkers and the people in this region, and for people who are saying, you know, it's not any greater than the flu, or you know, it's over-reported, overblown. These are a couple of slides I wanted just to address that issue. This graph was put together, it was in the New York Times, but it was put together by data from the New York City Department of Health for all-cause mortality. And on the vertical axis, it goes up until you know, this 8,000 number here on the vertical axis. And on the horizontal axis, it's from year. This is the causes of all deaths put together, everything put together, car accidents, heart attack, stroke, everything. And it's each data point is by a month, right? So you see that in each year there are fluctuations of death, but somehow there's a range of total deaths that go somewhere in the high 3,000s to the, you know, mid 5,000, something like that. On September 11th of 2001, you can see that there was a spike in the month of September, obviously from the World Trade Center. Now this graph finishes on April 4th. And on April 4th, you can see that there were 9,780 deaths counted so far. This does not include revisions to this estimate now, but there have been around 16,000 deaths. So this number would now jump off of your laptop or iPhone in a way that is almost inconceivable. So something big went on in New York City, and much bigger than the previous years. What I really want to focus on here is some of the good news, okay? Some of the good news is that social distancing works. And I think what the message for my talk today is that what's really important about this idea of testing, continuing social distancing, each governor and each community making decisions about when to loosen their social distancing or stay-at-home policies. Really, it depends on the capacity of the healthcare system to manage the new cases, which will be coming, right? So even with the maximum, you know, sort of social distancing, not stay at home, but opening the economy, we know that we're going to see increases in transmission. That's normal. The question is, if we need healthcare and we need to be hospitalized for that, can the hospital system manage these transmissions? And so we have some indicators that here, this is a graph that shows hospital admissions for COVID-19 in New York City, starting in early March, and then this goes until, I think, a day or two ago. And you can see a nice curve there that the new hospitalizations specifically for COVID-19 have come down. Why have they come down? Because the city has been on this, lockdown or stay-in-place policies have been enforced. And as soon as we open those, we're going to see these numbers. We have to monitor these numbers, okay, and see how they grow. The reason that they peaked, obviously, in April was because of the transmission rates that occurred beforehand. So when we're talking about days, for example, somebody asked about this 14 days. So the incubation period for to become symptomatic is between 2 and 14 days. Please correct me if I'm wrong, you guys. Right. And then it takes a while for you to become sick enough to be hospitalized. So you'll see a little bit of lag in the calendar, right? And then when you're hospitalized and you recover, those numbers come out. But if you're hospitalized and are very severe and you go on a ventilator, it takes weeks for you to either die, which most cases of intubation do, unfortunately, end in death, or recover and come out. So you see these lags, but you see the same sort of curves happening with each of these, depending on how you look at cases versus hospitalizations versus deaths, okay? So this is, I think, the most important slide I'd like to message today, okay? This is from the Institute of Health Metrics and Evaluation, and it's a model which shows the needs or the total number of beds in New York. This is by state, not by city. This is the total number of beds available before COVID-19 and total number of ICU beds available and the shortage. So if you look at this table on the right, this is the total number of beds available in the state of New York and the bed shortage compared to all the beds needed. So every hospital in this region had to reconfigure entire wards in order to expand their capacity to be able to treat people who were hospitalized with COVID-19. And the reason this is important is that capacity can only be raised so much. And when you reach a point where the needs of this patient population surpass your capacity, then you're forced to do something which we didn't get to in New York, came this close, but you're forced to start making rationing of care decisions. And each of the hospitals that were in the epicenter had to have ethics committees come together and make these criteria about who would get care and who wouldn't if there was this exceeding capacity. And so this line, the purple line, is all beds available in New York State, and this peak shows you the number of beds that were actually used, meaning it's above the normal. And so this is the decision that we need to make as a society overall, okay? Whether or not you feel that your freedom has been restricted, or you feel that you're at low risk, so you should be able to go back. These are all important decisions, and the economics of this are severe. This is not our conversation on this call. The economic consequences of the stay-at-home policy are severe. Public health people understand that. We know that that leads to greater health outcomes and disparities. But what we're saying is we have to be careful to not surpass our hospital capacity, our abilities to care for people who are going to be sick. So that's, I think, the peak resource was used April 8th, and that's the good news about this story, is that now in New York City, we do have hospital capacity available for other causes and for COVID-19 as well. And this is the same data institute that shows for New Jersey, where it looks like our peak hospital resource has been on April 14th. Somebody in the chat asked about deaths and how we've had this sort of spike in deaths in New Jersey the last couple of days. I would remind you that deaths happen many weeks after this peak curve, right? Because deaths happen After your incubation period, 2 to 14 days, and then another couple of weeks of being sick and trying to manage at home, and then going into the hospital and then having hospital management try to help you as best they can. And then unfortunately, some people die. So that peak is not a sign that we're having increased new cases. It's a sign that we still have a lot of cases who are unfortunately very sick in our hospitals. So I hope that
the graph you showed in the previous slides, Kim, if you can go back to that, the decline in this mountain was not because the virus got eradicated or the virus disappeared or because the weather changed. The virus has always been around, hasn't gone out anywhere yet. We'll see if the summer will change anything, but it's really because we stayed home and we reduced the transmission of this very contagious virus.
Exactly. So if you can recall, New York City had their stay in place policy implemented on March 22nd, right? So you see this peak, but this is a 14-day peak here. And, you know, and then you see that basically 14 days or 15, 16 days from March, from then, you see this decrease. Now, the idea that New York closed a week later than some other cities in the country may in part explain some of the differential, not all of it, but some of the differential in the city. So that's New York, New Jersey. And I just wanted to show you, again, this is from the New York City Department of Health. And we want to be below the dotted line in terms of the number of people admitted to New York City hospitals for COVID-like illness. So the reason that we promote massive testing, aside from having a worker who doesn't feel well on a Monday, right, and needs to know, go on Monday to Raffi's urgent care center, finds out he or she is positive, isn't able to stay home as a result of being positive and not infect other people at work. In addition to that testing capability, we as public health surveillance epidemiologists, we need to see on the population level when we start to see these increases, so that in case we need to do another temporary stay at home, so that we don't get beyond our hospital capacity. So I hope that that message is clear with these slides. Now, I want to show you an interesting map of New York City. This is a map of New York City by COVID-19 cases based on patient addresses. So this is of when a patient gets admitted to a hospital or goes to a clinic setting, gets a positive test, and has written down their address in that forms. This is the data collated from that. And what it shows you is that in those neighborhoods that are poorer, right, and where there's greater level of poverty because of lower income, greater increases of food insecurity, greater dependence on public transport, lower abilities to get protective equipment and masks, lower abilities to not go to work, right? These are the communities that are hit the hardest here. And interestingly, these are the same zip codes where you'll see higher rates of hypertension, obesity, diabetes, and those conditions that that put you at greater risk for having an adverse outcome. So this is just case. This map is on cases. The same site you can go into and look at. It's fascinating. You can look at hospitalizations and deaths. But you know, cases, hospitalizations, and deaths have a related, you know, they have a relationship to another. This is just cases.
This is also interesting, sorry to cut you, but yeah. This map remains the same if you only see what you described. This is actually access to testing, this particular map. So you see Staten Island, that looks very, very dark purple. It's because they had very early on drive-through testing and many, many more access to testing. So it's not just who has access, and then you look at who has access, and then if you have access, what percentage are positive.
So that's, you brought up a great point, because one of the factors that leads to New York having this incredibly higher number of cases is in fact that they had much higher testing per capita. So per 1,000 people, they had, I think, 5 times greater testing than did other similar communities across the United States. And So therefore, we have these higher total numbers of cases. But the idea of the mitigation shutdown date, I think that's also very important, that San Francisco shut down about a week before New York did, with fewer cases. There seems to be some sense that there must have been community transmission going on a lot longer than we're aware of. And New York is the most dense population density factor is the highest in New York. There are other cities that have high density, but there's a litany of other issues here about public transportation and perhaps communities with higher comorbidities that, you know, I haven't really been able to flesh out. But it seems that New York, for a number of reasons, it describes why New York is so much greater than.
There's beautiful what we call genomic testing, guys, where the scientists are looking at the genes of the virus from different patients, both in New York and California. And in both states, it's very clear that the virus was, and also Seattle, Washington, that the virus was circulating a month before we identified the first case. So you might have heard in California, there were some people who died, like Raffi said, they were coming early. Maybe it's the flu, but the flu test was negative. So the Department of Health sent some of those dead people's samples to the state to be tested, and they turned out to be positive early February. And here also in New York, we're tracing back the virus to February when we were not doing any distancing. And that's why in March we had that delayed peak, like Kim explained. It takes 2 weeks to develop symptoms. So if you were exposed in the middle of February, you're going to become sick in March. And that's why it spread in New York so much, and it was spreading already for a month before we could test and detect.
So I hope that answers one of the chat questions, which is, yes, there is population density, public transportation, inabilities to not go to work, the large service sector that had to continue to go to work or weren't able to move to remote work early on before there were these stay-in-place policies. That's all part of it. The amount of testing is higher. Mitigation shutdown was about a week later. And there's this set of underlying comorbidities that probably put us at greater.
We have to be number one in everything, guys, in New York City. So we're number one in this too.
As of today, we have
in a bad way.
As of today, we have approximately 18,000 deaths in New York City alone, and 166,000 cases, which obviously is a huge differential.
That's 6 weeks, guys. Daily 300, 400, 500, 600. In its peak, 700, 800 people were dying every day. Every day. So
I was asked to put up this type of a slide. I think, Tsoline, I don't know if this is, that just puts coronavirus in perspective with other projected leading causes of mortality in the United States. And the thing is, the reason this circle is, you know, there's this yellow circle and then this beige circle around it, is we really don't know what the total will be yet in 2020. And that all depends on how well we continue these social distancing and infection control mitigation policies. Now, as we open up the economy, we are going to see transmissions increase, but maybe human behavior will adapt in a way that can, you know, control the transmission. And then when we don't see that happening, we need to sort of shut down temporarily, get enough hospital capacity, open up again. It's going to be a little bit of a staggering response. So we don't really know. But I think this puts it in perspective. You know, we got heart disease is the #1 leading cause of death around the world, and then followed by cancer, and then stroke and Alzheimer's. So, you know, this COVID is somewhere between 88,000. We're at 66,000 now, I think, in the US.
Yeah.
So the lowest model shows 88,000. The highest model shows 293,000. Again, all depends on how we socially mitigate. Now, this was the same source looking at how it compares to the flu virus of 1918, 1919, right, where 675,000 people are estimated to have died. And then the flu of 2018 season and 2017 to 2018 and 2018 to 2019. The thing I just want to point out about this number, and this is what drives people crazy because it's really not apples to apples comparisons. The flu number is an estimate number, where the CDC reports about 6 times, they utilize like a proxy number. And so they take the actual flu positive cases that they have reported that died, and they estimate with an algorithm that has been in use for a long time, and they estimate that by 6 times. Right now, we're not doing that with COVID-19. So if we were to do something similar, this circle would be a lot greater than the flu. What we do know is that the COVID-19 is more contagious than the flu, that 2 to 3 people in an area can get infected with COVID versus, you know, 1 with the flu. And guys, the flu has been around. We have some level of exposure and immunity. We have the vaccine. We have ways to mitigate the impact of the flu. We don't yet have those ways for COVID-19. So it's really not a fair comparison.
And if the asymptomatic transmission pans out to be a substantial proportion, that's also, you know, something different from the flu.
Right. So flu has a shorter incubation period, and transmission is really with symptoms. So all of this stuff, we really can't, I don't like these comparisons, and I don't like to delve into them because the data is not the same. They're not equitable. But at the same time, I know people are looking, I mean, I see in my social media feed that people are talking about this comparison all the time. So anyway, just to conclude, that this is just New Jersey's graphic on this, that what do we need to open up? Some of you are in states where you have already opened up. Some of you are impatiently waiting for that to happen, for your businesses, for your families, for your kids to go back to school. These are some of the principles that New Jersey has put together on their website. So sustained reductions in COVID-19 cases and hospitalizations. We have that. I just showed you that data. Expanding testing capacity. Raffi talked about that in his urgent care centers. There is expanded testing. We haven't met the full indicators that have been analyzed and described, but we're on our way to getting those testing indicators. We're just not there yet. Implementing robust contact tracing. That's if somebody is positive, somebody comes to Raffi's center and is positive, then Raffi needs to put that into a database so that his county can then contact people at that person's workplace or family or school, so that those people can also then go get tested. That we don't, you know, public health is one of those public sector budget line items that really has never received the amount of money that it needs to do its job well. So that is being ramped up, but we're not there yet. And then securing safe places and resources for isolation and quarantine for those individuals who are not able to self-isolate because of their living situations. This is an issue. Armenia is providing a place for self-isolation and quarantine for every single positive case that they get, which is amazing. I don't know how sustainable that will be over time. Right now, the rate in Armenia has stabilized. And then they have this, you know, an economic restart in stages, and they're looking at New Jersey's resiliency, which again is looking at the capacity of the hospitals and healthcare workers to take care of people who are sick. So I'm going to end with those slides. I have other slides for Armenia, but I think that the hour is getting late.
So we'll go a little bit longer. There was a question about Armenia, and I know that's a long subject, but Kim, would you mind just mentioning a few things about Armenia?
So I'll just say that Armenia, it has good testing capacity. If we look at those 6 numbers, Armenia is they're about to start this week and next week, the relaxation. I don't really like these words, but that's what they're called, relaxation of social distancing policies. Armenia has decent testing capacity, and they have not surpassed their hospital capacity. And that's what I can say. And that there seems to be a stable linear increase of cases rather than exponential increase of cases. They're doing massive public service announcements, but we are all reliant on everyone in the public following infection control behaviors, and that's just it's hard to rely on that. And so there are going to be clusters, and they've contained a few villages because of clusters, but I feel like they're doing given the resources that they have, I've been nothing but impressed with the public health response. I'll leave it at that.
Great. We do have a specific medical question. And this really gets to us learning about coronavirus. There's so much that we didn't know in March. There was information from Europe and information from China, and that was one of the questions. How valuable was that information? But there's information about the disease. And one of the things that we've learned recently is the risk of stroke and complications of blood clots. Dr. Kojaoghlanian, can you tell us a little bit about the veracity of the data we've received? And the second part of the question, a little bit about the stroke complications related to coronavirus.
Yes. So as you said, when the disease hit the US and we have so much flood of information on a daily basis about different characteristics of this disease, we do, as the person asked, have seen in a subset of patients, and this is happening both, by the way, in young, healthy individuals, obviously much less frequently than older individuals, but they're both presenting with what we call neurologic manifestations, such as stroke, and sometimes people, because they're told don't go to the emergency room until you're, certain way, it's missing the opportunity of intervening and doing something to prevent further damage. And so, and as the person also asked, there is other evidence that some people are getting better, and then all of a sudden they are dying suddenly from the disease, and those, what we call, they're throwing clots into their lungs, what we call pulmonary embolism. So that's another evidence that there is some sort of dysregulation of the clotting system in our body that this virus is inducing in certain individuals. So the question was, are we prophylactically or preventively giving anticoagulation to patients when they are admitted? I would say yes. Most hospitals by now have a protocol and guideline as to who would qualify and what type of anticoagulation to be given depending on their other comorbidities. But yes, almost everybody is being put on some sort of anticoagulation, especially when they are in the hospital. And then if you already have risk factors for coagulation, your doctor might also choose to give you anticoagulants when you're still at home with moderate illness. That's why even when we're saying that, yes, don't come to the doctor if you're not short of breath, but you still need to keep in touch with your doctor. And again, this is where testing is important, because if I know someone has COVID-19 rather than allergies, let's say, then I might, again, see what risk factors that patient has and give medications accordingly, such as anticoagulants to be taken. So I'm not going to say more about that because that's really a case-by-case basis. Not every single person should be on anticoagulants, but yes, hospitalized patients have protocols for that. And the same phenomenon that Raffi was describing in the toes, when people are presenting with swollen, almost purplish looking toes, is also something that is being attributed to these little clots that are being thrown at the distal extremities, or the toes and the hands.
And
the hands not as much, but the toes.
It goes to show you, I think there was several young youth, maybe 40 to 50-year-olds in the New England Journal of Medicine. They were talking about how they avoided going to the hospital and they were having stroke symptoms and no known real risk factors. And they all needed clot busting medications. Some had extractions done. So very strange, but yes, this virus is surprising us in so many ways as far as the way it's attacking us and affecting.
Larry, I'm sorry to interrupt the question, but there's a series of questions I think that I'd like to ask for Tsoline and Raffi, which is, when we go out, as the economy opens up, we go out, we go back to work, people want to know two things. They want to know, there's a question about use of gloves, if you can't wash your hands. There's a question about this idea of masks and how protective they are. There's another question about when you can go back to get your own elective procedure done, that all have been, mammograms, endoscopies, cancer checkups, all of these things, CAT scans. Could you talk a little bit, both of you, about how we can help our community make decisions on when to go and what behaviors they need to do individually to lower their risk for infection?
I'm going to do the pediatric side, Raffi, and you do the adult side. So for us, there is the fear that many parents are worried to take their children to the pediatrician and give them their vaccinations, especially those under age 2 who are vulnerable to diseases, very, very serious diseases that can kill a child, really, such as measles, such as meningitis, pneumonia. So every single hospital, trust me guys, and clinic, if they have any conscience, are making sure every day in their huddles and meetings with their staff that they want to do everything possible, starting last week actually, to create a safe and healthy environment so that patients can feel safe to come in. If you go to a place and you don't feel safe, leave. So what does that translate to? Like Dr. Raffi said, the waiting rooms are no longer going to be like in the past where there is 10 people in the same waiting room. So measures that might be put in would be that each person's appointment is really spread out. So my appointment is at 10, Raffi's is at 10:30, Larry's is at 11. So that's actually going to damage the doctor's office because we're going to see less patients. But that's the way you're going to know that when you walk in, you're the only patient there. In addition, obviously, the doctors are going to be wearing PPE, and therefore, again, you shouldn't worry that you're going to catch the disease in the clinic because all the staff are going to be wearing appropriate PPE. And so we urge all parents to take their kids, especially those under 2, to make sure that they get their vaccinations. And there's going to be a lot of telehealth, also medicine, that many clinics are adopting for those patients that can be assessed by video. That's something also that most doctors are going to be setting up until we come out of this completely. But anything that's urgent, anything that doesn't feel right, you really need to bring in and make sure it's taken care of.
Yeah. I mean, to parlay on what you just said, I mean, ultimately there's going to be a new normal, and we're going to have to all work together to make sure that that new normal is something acceptable. I mean, even Dr. Fauci said he doesn't know if anyone's going to be shaking hands anymore and this and that, which is amazing, especially with our culture, right? We always like giving a double-sided kiss and all that. I mean, who knows what we'll be doing down the line. But ultimately, I think the other thing that you were saying, people going to the pediatrician, there's plenty of my colleagues that are gastroenterologists, cardiologists, orthopedics. When are they going to start to open up elective procedures? Again, I think it's the way we're doing things in my office. They're going to have to do the same thing in their offices. They're going to have to protect each other, protect their patients, and do things the right way. And as we slowly open up with baby steps, it'll be okay for patients to get their elective procedures, because a lot of these patients need things done, whether it's cancer, knee replacements, this and that, but it needs to be done properly.
Just to give an example, is our hospital is doing same-day testing before your elective procedure.
Yes.
So again, most hospitals in our area, because we've been hard hit and hospitals have been working very hard to meet everybody's demand. So right now, most decent sized hospitals have same-day testing in our own hospital. So let's say you have an elective surgery, you come in at 8 a.m., you're put in an isolation room, they swab you, and 2 hours later, you know your test result. If you're negative, they proceed with the surgery. And if you're positive, you're sent home and your surgery is rescheduled. So there is same-day testing so that if you have the virus, you're not going to be put under anesthesia, and you will also protect the surgeons and everyone around you. The second thing is most hospitals are also having COVID wards and non-COVID wards, right? So again, if you do proceed with your surgery because you were negative, you will be put in an area that is, again, full of people who don't have the disease. So a lot of measures being done in hospitals to make sure that there is no cross-contamination between COVID positive patients and COVID negative patients.
And patients are coming to us. Certain doctors are sending them in for medical clearance, just like they always did. We're doing the same thing. We're clearing them COVID-wise as well as medically. And then as long as everything is cleared, then they'll proceed with elective procedures. But that's being done very slowly.
That was wonderful. We are coming near the end. We try to answer many of the questions. There'll be some more questions. There's 2 we can probably answer now. But if you have questions we did not answer, please email us at info@ahpo.org. There's one question about remedies that may boost the immune system. There's a great deal of talk about garlic, there's zinc. Can we get an answer about any of these other remedies that might boost the immune system and protect us?
I think there's a lot of anecdotal. People say a lot of things about garlic and vitamin C and all these things, and I don't think the evidence out there is on and off. Like just like vitamin D, this and that. Everyone's like, yes, take this, and then next year they're saying no, it's not good for you. So I mean, yeah, you can try and take certain types of things, but we have no evidence base to show that that's going to boost your immune system and prevent you from getting COVID or flu or any of these diseases. So I would take all that information with a grain of salt. A lot of that is just spending a lot of money for no particular reason. So I would say be careful with those remedies.
100%. And there is the risk of overdose, especially with vitamin D.
Correct.
If you don't take it correctly, you're going to put yourself in trouble.
Exactly.
So, all these vitamins are in healthy nutrition, guys. So make sure you eat your vegetables, your fruits, you exercise within whatever exercises works for you. So we're not going to create athletes because of COVID-19, but we're saying that we need to have as healthy of a lifestyle as possible.
Dr. Hekimian, I think you wanted to say something.
So, I mean, sometimes I feel we get on these webinars and we just give sort of, we don't want to leave you without telling you and reminding you that the overwhelming majority of people who do get the virus will have mild symptoms. Again, you have a way of assessing your own risk. We're asking the population to also take every measure possible to keep the risk down for those who are more vulnerable. And I think that's the ultimate message here. We have more testing. There was a very quick, just a quick answer to one of the questions is that the test for whether you have the virus today is a test that is recommended by Tsoline and Raffi and is considered more reliable than the antibody test, which whether you had the disease in the past and your exposure led you to build an immune response. So the testing message here, if it wasn't clear, is that you should go and get tested if you believe you have the virus, or as Tsoline mentioned, you're having a procedure. And the test for whether you had exposure, you can get it, but your abilities to interpret what that means for your life and your behaviors is not reliable, if that helps clarify that. So I just wanted to end on that the majority of people, we are going to have a large number of Americans that are going to be infected with this virus. We don't have a way of preventing that other than social distancing, washing our hands, not touching our face, and wearing masks in public, right? We don't have other greater ways of doing that yet. There's not a vaccine, there's not a cure, there's not a particularly impressive treatment. So in the meanwhile, we all have to practice these.
So again, I want to thank our panelists. You were all wonderful. You each shared your ideas from different points of view. I also want to thank our audience. Your questions were incredibly articulate and really helped stimulate a great discussion. It's really incredible that almost all of you stayed on the whole duration. We will be sending us an executive summary as well as a link to both this and last week's tape. If you do have any questions, of course, email us at info@aahpo.org.